and I would like to start our next session. And I would like to call the first authors Henok Teklu, PhD candidate, Meret Deminisse, uh, PhD from Alma Mater Europaea University, to represent the article with title ECG heartbeat classification using CNN liquid neural network architectures, a novel approach with GAN-based data augmentation. The word is yours. Thank you very much.
Hello, everyone. Can you hear me now?
Yes, we can hear you.
Okay. Um, so my name is Henok Taklu. I'm a PhD student at Alma Mater in Applied Artificial Intelligence. Today I'm going to present to you about our ongoing work about how we can use CNN algorithm by combining a liquid neural architecture. Uh, this is an like kind of a novel approach because somehow we add also a data augmentation for those small classification data sets. We use a GAN-based generative adversarial network based augmentation work. So the overall overview of the work includes what is the research motivation here, what is our novel contribution that we did, what kind of data sets that we use for this kind of problems, how we dealt with imbalanced data sets using generative adversarial network and LSTM as well. The overall architecture that we did and we use, including CNN, LNN architecture, in addition to attention as well. Uh, why liquid neural network is important. And we also have seen the comparison between different algorithms as well as with the previous works. And finally, we'll see how we can do infer from all these informations. So what is the research motivation here? Why automated ECG classification needs a better breakthrough? We already have like a lot of breakthrough with these data sets, but we need to do in combined liquid neural networks. The other one, like the best thing is we have a data set with a very imbalance that we have normal beats of around 90% data set is a heartbeat with a normal arrhythmia, and there is like a very small amount of data set that we have that is a very life-threatening arrhythmia, which is less than 1% from our data set. So we need to make sure that our data set is somehow balanced for these kind of problems. Second one is since, as we know, that the heartbeat is a complex temporal phenomena where there is like a very complex temporal dependencies. So we need to make sure that we have to capture this kind of dependency to each other using a specialized algorithm such as liquid neural networks, where we need to deploy this kind of algorithm. So we we don't often need to depend on the cardiologists because sometimes this kind of behavior can create delays, diagnosis error, and limited access in resource constraint setting or places. So this is a recurrent approach, but traditional recurrent networks fail to adaptively model different temporal scales without manual tuning. So We need to make sure that our recurrent temporal scales need to be dynamic instead of just making them constant, because the heartbeat the whole signal is more of dynamic instead of just like a temporal or fixed temporal scales. So what is our base contribution that we use? Firstly, this is the first LLN application that we did for this kind of problems, for ECG problems. So this makes it more unique. The other thing is we have combined advanced data augmentation approach instead of just using a simple mode and other data augmentation approaches. We have used advanced two algorithms. One is the LSTM, and we have used a GAN, a conditional GAN. So this can help us to preserve the ECG temporal characteristics for those minority class syntheses. Other is as optional, since informations are vast, we need to make sure that the most important features only the most important features need to pass into our readout informations. So we have applied attention algorithms, multi-rate attention with 8 heads. This would enhance the focus on discriminating ECG features. We've done a lot of evaluations from previous works as well, and also we have developed two distinct algorithms in our case as well. This has created a higher accuracy of 98.1 accuracy. This surpasses the previous state-of-the-art approaches by 1.3%. So the dataset that we have used is from a MyTBH dataset. As you can see from this dataset, we have a total of almost 110,000 heartbeats. The recurring were like so as you can see from this, the imbalance ratio from a normal and this abnormal arrhythmia classes that you see is 1 to 93.4%, which is very large. So we need to make sure that this gap need to drop. So the other sampling rate, our sampling rate is 360 hertz per second. So it will just somehow capture all these spikes and other heart rate features as well. So once we have these things, we just filter it into a certain bandwidth, and also after we filtering, we segmented all the pointers into 100 pointers for a training purpose. So how we did data augmentation. Data augmentation is something that we somehow create a fake data based on the available data sets because we don't have enough data set for some of these minority classes. So what we did is we come up with some kind of generate some kind of data set based on these minority classes. Then we have two important elements. The one is the one that creates those fake data sets based on the available data set, and the discriminator just tries to look on the data set itself and try to make sure that it just identifies whether it's fake or like non-fake. At some point, the generators will be more intelligent. They somehow trick the discriminator to assume that those fake data sets are real. At that point, that means like we have made some static data sets that somehow resembles those minority classes. We have used 100 dimensional latent vector class label. We used a bidirectional LSTM to create those data sets. We have applied hidden layers since three hidden layers, which we also like use batch normalization, as well as we have used some kind of drop for make sure that 30% of neurons are not active. And we have applied tanh output, and it generates a fake data of the same 100 pointers, similar to that we have in the data set itself. And the discriminator will use the same approach with the LSTM method, but the generator iteratively becomes more intelligent, and the discriminator somehow fails to classify any synthetic or fake data as fake. So this way we generated, as you can see from this data set, we have a small number of data set originally from those the minority classes, but we have multiplied them into multiplied them 200 or 300%. So what is the architecture that we used? As I told you, we have combined the power of CNN. CNN can help us to distinguish spatial features, and the LNN helps us to identify or just map these adaptive temporal modelings. So we have an input from ECG. We just have 180 pointers. We pass that like pointers into CNN that extracts important features from these 100 pointers. Once we have this extracted feature, like lower dimensionality vectors, that we pass this through LNN temporal modeling. The LNN somehow understands about what is the recurrent information that we have inside that extracted feature. And as option, we have adapted attentions. Now we have like these temporal features, but the attention algorithm somehow will have some kind of attention in it. So it just make it the algorithm more faster, so the algorithm more to be more accurate. And finally, we use this fully connected algorithm, and we compare it with output. So this is how the feature works. We have like 4 blocks of convolutional neural network with filters 3 to 1, and we have batch normalization. We have used array activation and maxpol. Then we have also used dropout of like 50% of the data set, 50% of the neurons as well. We have did same approach for the LNN. LNN uses a hidden unit instead of just layers. So we have time constant data sets. This time constant is based on the data set itself, instead of just using this like the same time constant that we use in LSTM and other recurrent neural network algorithms. We have tried to use adaptive one based on the data set itself. Because it's adaptive, when we have like some higher rates, anyways, we have like used some kind of adaptive approaches instead of just using a single rate. So the leak rate that you can see is dynamic, and we have used like neuron connection to each other, and we have used inputs with this way. We will have like this kind of changes like based on derivation, instead of just using time constant as a fixed values. So to explain the LNN algorithm, it is continuous time ordinary derivative equations based on temporal modeling. So this is how it works. This is a continuous time instead of just a fixed time. That means we can have a change of like any inputs with the change of time. That means like any changes are based on continuous time. It doesn't have to be like step by step. We can somehow use a very small changes, which is unique to LSTM that uses basically like a constant step. That means this will like passes some very important features, especially those who like changes like rapidly. just to capture those information that change rapidly, we need to come up with some kind of algorithm that somehow mimics a continuous time instead of just fixed algorithms. As I told you this, the adaptive, like any list, any recurrent information, in order to just avoid the vanishing gradient, we use a leak rate. That leak rate is based on the input that we use, but in most often they use like a constant leak rate. But in our case, it depends on the data that we have. What information need to be kept, what information need to be removed is based on this adaptive tau as a leak rate. This helps us to just focus on very important historical information rather than all of the historical informations. Of course, we have adapted neuron connection, different neuron connections, and we have an input from the CNN extracted value. This makes the whole algorithm stable, gradient. Instead of just using a typical backpropagation, we use a closed form solution to prevent vanishing gradient or exploding gradient. This reduces a lot of variations. It is easier just for interpreters as well. State dynamics reveal multi-scale temporal processing and biological plausibility causality. This is how our real mind works. So this is the training configuration that we have. We have as optimizer ADAMPUS like optimizer with different hyperparameters. We have used learning rate, a small learning rate, and it is the learning rate like changes based on certain informations. We did some kind of regularization that helps us somehow for the algorithm to predict on the unseen features or unseen elements. We use lasso regression as kind of regularization. Also, we have used dropout and batch normalization also used as regularization technique. We have used an epoch of 100 for a training purpose. We used early stop as well. We have split the data set, 20% of the data set for validating the algorithm itself. We use a categorical cross entropy loss function. We have used a very small hardware that we can mimic or we can have as information. Training is done with 80-20 training test split. We used precision recall and F1 algorithm as output matrices. And just to use, additionally, we used macro weighting average. So this is how the algorithm performs with the current algorithm. We have the CNN LNN without GAN augmentation. What if the algorithm first works with without GAN, without any kind of augmentations. So as you can see from this, some of the classes are they have like a lower F1 score. Some very critical. Some of them are very critical. Some of have like a very poor F1 score when it comes to a lower minority data sets. This is before using a GAN augmentation. So after doing like a data augmentation, we managed to increase the F1 score for those minority classes. Some increases by 44%, some with 67%. The total accuracy have jumped from 95 to 97%. This is what it looks like now with adding on top of using CNN and LNN, we also have added attention. Attention also have made the algorithm to be more accurate. So as you can see from this one, some of the classes have jumped the accuracy, the F1 score. So adding attention also have some kind of benefits on instead of just using data augmentation as well. attention has also made the F1 score to jump. So there is like an impact of adding GAN
Sorry,
augmentation.
can you consider ending because of a time limit?
All right, just I have like one is like
I'm
slopes.
sorry.
So this is the state-of-the-art comparison before like previous works. So our approach using CNN LNN alone and also CNN LNN with attention have somehow beat the existing state-of-the-art algorithms. So this is the feature work. So we will just do more directions, and thank you very much. Appreciate it.
Thank you very much. Now I would like to call our colleagues. Martina Hrvačić, PhD candidate, Clinical Hospital Sveti Duh, Suzana Uzun, Professor, Department of Psychiatry Vrapče, Institute for Biological Psychiatry and Psychogeriatrics, Reference Center for Alzheimer's Disease in Psychiatry, Mariana Penava, PhD candidate, Department of Psychiatry Vrapče, Sara Glavaš, expert, Croatian Institute of Public Health, Stefania Kolačko, and other Clinical Hospital Sveti Duh. They will present the paper titled Metabolic Approach in Biomarker Discovery for Diagnosis and Monitoring of Dementia. You can start your presentation. Where we will present the common paper. Ms. Hrvačić, do you need some help?
We cannot hear you, so if you maybe, even if you have your microphone turned on, maybe you don't
Can
have
you
it
hear me
plugged in.
now?
Yes.
Oh, yes.
Okay, sorry. I will share my presentation. Hmm. Can you see?
Yes, no, maybe if you put it on full screen.
Full screen, full screen.
Imate tu ja, tu. Super, vidi se sad.
Good afternoon, everyone. My name is Martina Hrvačić, and today I will present our research on metabolomic signatures in dementia, focusing on the differentiation between Alzheimer's disease and vascular dementia. In this presentation, I will explain the significance of metabolic biomarkers in early diagnosis and their role in understanding disease mechanisms and how they can potentially improve patient care. The two most common types of dementia are Alzheimer's disease and vascular dementia. Alzheimer's disease is primarily associated with amyloid plaque accumulation and tau protein pathology, while vascular dementia is caused by reduced cerebral blood flow and vascular damage in the brain. Although these diseases have different underlying mechanisms, their clinical symptoms often overlap, making differentiation challenging. This presentation will explore the role of metabolomics in dementia research. We aim to identify specific metabolic changes associated with cognitive decline and investigate their potential to distinguish Alzheimer's disease from vascular dementia. Dementia is a complex neurodegenerative syndrome that affects millions of people worldwide. It is characterized by a progressive decline in cognitive abilities, including memory, learning capacity, abstract thinking, and spatial orientation. These impairments significantly affect daily functioning and reduce the quality of life of patients and their families. Metabolomics is a modern research approach that analyzes metabolites, which are small molecules representing the final products of biochemical reactions in the body. Since metabolites reflect ongoing physiological and pathological processes, metabolomic analysis can provide valuable insights into metabolomic changes associated with dementia and cognitive decline. In dementia research, metabolomics allows us to detect metabolomic alterations related to neurodegeneration. These changes may occur even before clinical symptoms become evident. Therefore, metabolomic studies can help identify early disease markers and support the discovery of specific biomarkers that may improve diagnosis and also monitoring. Okay. Our project has several main objectives. Firstly, we aim to discover new and accessible indicators for diagnosing Alzheimer's disease and vascular dementia, allowing timely intervention. Secondly, we seek to identify metabolites associated with cognitive decline, shedding light on the underlying mechanisms of dementia. Also, our overreaching goal is to apply metabolomics to uncover specific biochemical changes associated with each disease. Our aim is to identify readily accessible indicators that facilitate precise differentiation between these conditions. Our study involves 150 participants, 50 with mild cognitive impairment, 50 with different stages of Alzheimer's disease, and 50 diagnosed with vascular dementia. Blood samples are collected, proceed, and stored for metabolomic analysis using state-of-the-art technique. We use two techniques, gas chromatography, mass spectrometry, and liquid chromatography, mass spectrometry. Most studies use advanced mass spectrometry techniques to analyze metabolites in plasma, serum, cerebrospinal liquid, and brain tissue. Research has identified alteration in several groups of metabolites, like lipids, amino acids, and their derivatives, organic acids, and energy-related metabolites. Key findings include reduced level of sphingomyelins and phosphatidylcholins in Alzheimer's disease. Disturbance also in lipid metabolism and changes in amino acid metabolism. We can see a lot of research, but we will not stop our research. Some studies propose metabolite panels that may help distinguish Alzheimer's disease, mild cognitive impairment, and healthy controls. Our projects anticipate several outcomes. We hope to identify metabolites that can serve as potential biomarkers for diagnosing Alzheimer and vascular dementia. Additionally, by examining metabolite changes linked to cognitive decline, we aim to contribute to a deeper understanding of dementia progression. The implications of our research are profound. By developing reliable biomarkers, we can enhance diagnosis accuracy and enable earlier intervention, improving patients' quality of life. Furthermore, understanding the metabolic basis of dementia could lead to novel therapeutic strategies, revolutionizing dementia care. And in conclusion, our research endeavors to address the pressing challenges posed by dementia. By harnessing the power of metabolomics, we aspire to unlock valuable insights into the early detection, differentiation, and potential treatment of Alzheimer's disease and vascular dementia. Our dedication to advancing medical knowledge and patient well-being drives us forward. Thank you for your attention. And also thanks to the Department of Molecular Medicine, Ruđer Bošković Institute, and professor, and so on. Thank you.
Thank you very much for your interesting presentation. Our next representatives are Larisa Bosnić-Kovačević, PhD candidate from University of Zagreb, Faculty of Education and Rehabilitation Sciences, and she will talk about effects of maternal alcohol and marijuana consumption on child development.
Can you see?
We hear you very well. We can also see your presentation. Just go on.
Okay. Good afternoon. My name is Larisa Bosnić-Kovačević, and today I want to talk about a critical public health issue that sits at the very heart of human development. It is how maternal alcohol and marijuana consumption during pregnancy can shape a child's lifelong trajectory. It is a global public health challenge. Alcohol and cannabis are deeply embedded in many cultures, and their use is widespread. Critically, a significant number of women of reproductive age use these substances, and that can lead to exposure during pregnancy, which is a period of unparalleled fetal vulnerability. Here you can see that 400 million adults have alcohol problems, in which 35% of women are drinkers, and approximately 3.7 million adults use cannabis daily. When we look at the statistics of pregnant women, 5.4% of pregnant women in US used cannabis, and 9.5% used alcohol. Combined use is also very common. So I want to first start by looking at why this review is so important right here in Croatia. Globally, fetal alcohol spectrum disorder, which is one of the common consequences of prenatal alcohol exposure, affects under 1% of children in global. But in Croatia, the rate is 5.3%. That is nearly 7 times the global average and one of the highest rates in the world. And furthermore, while we have a lack of direct data on cannabis use during pregnancy in Croatia, we know that approximately 15 to 18% of young women report using cannabis. This is the prime childbearing age, and this tells us that we have a significant population at risk of exposure, often before they even know they are pregnant. And this combination, a high prevalence of FAST and a high rate of cannabis use among young women, creates an urgent public health challenge that we must address. With this critical local context in mind, I have conducted a narrative review of the scientific literature. My goal was threefold. First, I wanted to synthesize the vast amount of evidence on how alcohol and cannabis on their own can affect a developing child. Secondly, I wanted to explore a question of growing concern. What happens when these substances are used together? And finally, to take this global evidence and use it to inform our public health response here in Croatia. Before we dive into the results, I want to talk about the challenge about defining risky use. Defining excessive or at-risk drinking isn't as straightforward as it seems. One agency defines binge drinking by blood alcohol concentration, 4 drinks in 2 hours for a woman. And the other one defines it by pattern, 4 drinks on any single occasion in the past month. And these inconsistencies makes it very difficult to compare studies and create uniform clinical guidelines. This uncertainty is amplified during pregnancy. While researchers grapple with these definitions to study the effects, the only consistent, safe recommendation for pregnant women is very simple. It is abstinence. So when we looked about the effects of prenatal alcohol exposure, the evidence is clear and robust. It is a well-established teratogen. The most common consequence is FAST, or fetal alcohol spectrum disorder. It isn't just one thing, it is a spectrum of lifelong impairments. Physically, it can cause to distinguish facial features, low birth weight, microcephaly, and damage to vital organs. Cognitively, it leads to learning disabilities, intellectual disabilities, problems with memory and attention. The most common co-occurring condition is ADHD, which affects the staggering 66% of cases with FAST. And behaviorally, it causes to poor adaptive function, communication challenges, and higher risk of legal problems. As our review shows, this is a condition that affects the whole person, their entire life. And while some studies have shown mixed results for very low-level drinking, the overwhelming consensus and the precautionary principle leads to one conclusion, and that is there is no known safe amount of alcohol during pregnancy. When we looked about the effects of prenatal cannabis exposure, the picture is more complex but equally worrying. It is the most commonly used illicit drug among pregnant women, and its use is on the rise. Why many women use cannabis in pregnancy? It is simply to elevate pregnancy symptoms like nausea. And they believe that it is safer, natural alternative, but the evidence tells a different story. At birth, we can see clear links to premature birth, low birth weight, and higher chance of the baby needing intensive care. In the long term, the effects are on the brain. It can cause cognitive impairments, behavioral problems like aggression and delinquency. One longitudinal 22-year-old study showed that prenatal exposure can set a child on a trajectory towards early marijuana initiation, and that can lead to all sorts of problems in adulthood. And this brings us to the most critical and under-researched questions. What happens when a mother uses both alcohol and cannabis? Alcohol and cannabis are a common combination. They act on a different but interconnected system in the developing brain. Alcohol disrupts the primary wiring GABA glutamate, while cannabis interferes with the brain's key regulatory system, the endocannabinoid system. Together, they disrupt multiple neurotransmitter systems. Emerging researchers, including animal models, suggest that this combination is more damaging than either substance alone. It can lead to more profound cognitive deficits, greater emotional instability, and even structural changes in the developing brain. This is a synergistic effect where the combined harm is greater than the sum of its parts. So to synthesize our findings, the evidence for alcohol's harm is unquestionable. For cannabis, the evidence is mounting and undeniable. It possesses a significant and independent risk. And the emerging research on combined use is alarming, suggesting an amplified danger to the developing of fetal brain. This brings us to the bottom line, a message that is both scientifically sound and simple to communicate. For a healthy pregnancy and the best possible start for a child, the only safe choice is complete abstinence from both alcohol and marijuana. And to conclude, the evidence is clear, and alcohol and marijuana can profoundly and permanently disrupt fetal development. The risks are real. They are amplified when substances are used together. But here's the most important part. This is a preventable tragedy. And FAST and other harms that we've discussed are 100% preventable. So my hope is that by consolidating this evidence, we can spark a conversation and drive action in our clinics, in our communities, and in our policies. By focusing on education and support, we can protect the next generation and ensure every child in Croatia has the chance to reach their full potential. Thank you.
Thank you very much for your presentation. The next authors are Syed Ahmad, Idris Munir, expert Salt Innovation Organization, Silvia Mettel, professor from University School of Physical Education in Krakow, and they will represent the paper titled Speleotherapy for Asthma at Quera Salt Mine, Pakistan. You can start your presentation. Are the authors here from that paper? Syed Ahmad, Idris Munir. Anybody here? Sasha?
Didn't we? We just had Larisa Bosnic, no?
Ne. Oh, yeah.
Syed Ahmad is not here, but
Larisa was
Larisa
there. She
is
already
here.
met. Speleotherapy for asthma at Quebra Salt Mine, Pakistan. Syed Ahmad, Idris Munir.
Larisa, are you with us? You already had the presentation?
Yes, I had a presentation.
Yes.
Okay. No, Syed Ahmad, I don't see is with us. No. So let's go next to Borbala.
Yes, I will go to the next presentation. The authors are Borbala Biro, PhD candidate, University of Peć, Faculty of Business and Economics, to present the paper titled Determinations of the Perceived Importance of Health Technology Innovations Among Healthcare Workers.
Yes, thank you.
You are
Hello,
welcome to start the
everyone. Can
presentation.
you see my presentation?
Yes, we see your presentation and we hear you also very well.
Okay, and is it on full screen? I hope so. Now
It's
yes.
not on full screen.
It's not on full screen, so if you can put it on
Now?
full screen.
I think now it should be.
I think you're not sharing the right screen, so I suggest you click New Share.
Okay,
and share the whole screen. So the upper left option, it says screen.
Okay, now?
Yes, now it's good. Thank you.
Perfect. Okay, and I hope it will working also. Okay. the devil of the technique also find us, but I hope it will be not a problem. Okay, and it's working perfect. So, dear audience, welcome everyone. My name is Borbála Bíró, and I'm a fourth-year PhD student at the Faculty of Business and Economics of the University of Pécs. My research focuses on examining the adaptation and the effectiveness of innovative surgical procedures. My supervisor is Professor Beatrix Lányi. The title of my presentation today is The Determinants of the Perceived Importance of Health Technologies Innovation Among Healthcare Workers. So, what will this presentation cover? Timelines of the research, health as a megatrend, the situation of the consumer, or more precisely, healthcare workers, diffusion of innovation, adoption of innovation from the perspective of healthcare workers, the research methods, and the research results. Okay, let me start with a question. Have you ever felt uncertain about any healthcare innovation, such as a vaccine? Please raise your hands or do something. Okay. I hope so. Someone is raised the hand and highlights the relevance of this topic. And this is further supported by the following chart, which illustrates the rise of AI in the healthcare market. Okay, why is health considered as a megatrend? Health is a major issue that affects people's everyday lives. Health is a megatrend because it has widespread impact on society, it significantly affects the economy, and it's increasingly important in related fields. Okay, we also have to examine that the factors influence healthcare workers. So on a broad scale, these include the social and the societal factors, economic factors, trends, political and legal factors, technological and technical factors. This is the one of the most crucial aspects in this research. And one more specific level, the following factors influence healthcare workers: the media, the institutions, the infrastructure, and the opportunities for professional development. Okay, let's talk about the diffusion of innovation. To understand the concept of innovation diffusion, let's turn to Rogers' definition, which is diffusion is an innovation. Diffusion of an innovation is the process over time by which a new product gradually becomes accepted by the target market, potential customers, and society as a whole. Diffusion is strongly influenced by communication, and the message is linked to a new idea. The novelty of the idea gives the communication its specificity. So the four basic elements of innovation diffusions are the innovation, the communication channels, the time, and the given social system. Okay, the adaptation of innovation from the perspective of healthcare workers is a very, very interesting topic about this research. For example, when examining the acceptance of the healthcare innovation, two key models must be clarified. The first is the TAM model, which is the technology acceptance model, focuses on the acceptance, and the UTEUT, which is the unified theory of acceptance and use of the technology, examines both the acceptance and the actual usage also. Unlike everyday products, for example, an eraser, which is ready for sale as long as its functions properly and it's non-toxic, for example, but healthcare innovations require trust between doctors and patients. Without trust, patients may refuse an innovation, preventing the necessary trials and potentially leading to its failure. Research also highlights the importance of peer communication among healthcare workers, as they are more likely to trust each other's opinions rather than corporate marketing messages. So three essential elements of innovation is the invention, the adaptation, and the diffusion, which we discussed. Okay, let's talk about the research methods. A quantitative cross-sectional study was conducted using a purposive non-random sampling method among healthcare workers. A questionnaire was developed based on the literature review, and the data were analyzed using descriptive statistics, correlation analysis, and cross-tabulation analysis with IBM SPSS. And the aim of the research is the study explores healthcare workers' attitudes toward the latest technological developments, focusing on factors that influence their perceived importance of these innovations. I have one main hypothesis and two sub-hypotheses. The main hypothesis was healthcare workers' organizational position and openness to innovation are associated with the perceived importance of being aware of the latest healthcare technology developments. One of the sub-hypotheses was healthcare workers' organizational position is associated with the perceived importance being aware of the latest healthcare technology developments. And the second was the healthcare workers' openness to innovation is associated with the perceived importance of being aware of the latest health technology developments. Let's talk about the key findings. The following chart illustrates the association between organizational position and the perceived importance of being aware of the latest health technology developments. We can see clearly the organizational position influenced this perceived importance. Leaders more often rated knowledge of the new technologies as important, whereas employees staff, which the largest group, were heterogeneous with the highest shares both following new technologies and not following them. However, there are still individuals in all experience levels who do not consider it important to keep up with technological progress. Let's talk about the second chart. The next chart shows the association between openness to innovation and the perceived importance of being aware of the latest health technology developments. The chart results show us the openness to innovation also had an effect. Those who were rather or fully open more often rated technological knowledge is important. Among those fully open, more than 37% follow new technologies and almost 11% do not, indicating a nonlinear relation between openness, perceived importance, and behavior. However, the majority of participants still recognize the importance of staying updated. The conclusion, my conclusion was the first sub-hypothesis showed moderate correlation and the second sub-hypothesis showed a weak correlation, so I accepted both sub-hypotheses as well the main hypothesis. I would like to summarize the results. This topic is worth researching because healthcare workers are generally open to innovation. Healthcare workers in higher organizational position place greater importance of being aware of the latest health technology developments. More innovation-open healthcare workers place greater importance on being aware of the latest health technology developments. My final thoughts are the findings indicate that the higher organizational position and the greater openness to innovation are associated with stronger recognition of the importance of staying informed about the latest health technology developments. At the same time, the results suggest that valuing such knowledge does not necessarily translate into uniformly positive attitudes toward innovation itself. To continuously improve healthcare quality, it is essential to enhance trust healthcare innovation through effective communication. It can be a further research direction to make a qualitative approach with expert interviews should be conducted to further explore causal relationships behind the findings. Thank you very much for your kind attention, and I look forward to your questions during the Q&A section. Thank you very much.
Thank you very much for your very interesting presentation. The last presentation in that setting would be breast cancer detection through thermography, a systematic review. written by Mehdi Aliou, PhD candidate, Mit Bracic, assistant professor from Alma Mater European University, Shurta Regia Malai, I hope I did read it well, PhD candidate from University of Pristina, Medical Faculty, Psychotherapy Department. You can start your presentation when you're ready. Are the authors here for that presentation?
I don't see them online.
Mehdi Aliou is the first author.
No, Mit Bracic also no. Shkurta Retsaima also not. So I don't see anyone online.
Oh, okay. In that case, I would like to open the discussion session. If you have any question to the authors, just please go ahead. Any questions so far?
You can type your questions in the chat, or you can turn on your microphone and
Yes.
and ask the authors directly.
I don't have any questions in chat. Okay, if we don't have any questions, I suggest we take a 5-minute break and we will start again at we will start half an hour of break and we will start again at 40:30. Thank you very much, and I will see you then.
Thank you very much.
Thank you.
Okay, we see it now, but maybe if you put it on full screen. Mehdi, can you hear me?
Yes, hello. Okay.
I think you have a bad internet connection, so you have an option to, yeah.
Sasha, can we begin with the session? Yes. Hello, everybody. I hope we are all set in to begin with the new session. On that matter, I would like to call our first authors, Lovelin Marechal, lecturer, Balmi Belizaire, lecturer, and I'm sorry, I cannot pronounce the name of your institution. If you could introduce yourself briefly. And I'm sorry if I messed up. Are the authors present?
I don't see present the first ones, but the next.
Lovelin Marechal, Schmiederson Aujour, I guess. Okay. Shall we wait a little bit or shall we progress
We should
with the next
move on
one?
to the next one. I think
Yes.
Juventina is here.
Let's check of our next authors are here. Juventina Nigela, lecturer. Erda Ori, professor, Albanian University from Tirana. Pelvic disorders, problems and challenges in clinical management. Breda Senšek Papež, professor from University Clinical Center Maribor. The title called Preventive Care in the Health System, Impact on the Improvement of Population Health.
Hello.
Hello.
Hello. Can I share the presentation?
Yes, you're very welcome. You
Okay.
can share your presentation and start with it.
You can see the presentation?
Yes, we do, but maybe you can just put it on full screen.
Yes.
Okay.
Or if you click on the down right corner, the book.
Just a minute.
Do you see
Can
the
I con-
book?
Okay.
Do you see the book in the right side down? There is a little booklet, like you can press that and it will be okay. Or if you put it on full screen.
I'm trying, but I can't do for the moment. Can I continue
The
in
slides
this
won't
manner?
move for us, so if you can do without the slides, but I'm here to help, so you can
So,
click new share and then click on the whole screen option. It's in the upper left corner, but you need to click new share in Zoom and can share the whole screen. Juventina, can you hear me?
okay.
Okay, I will stop sharing and you just share it again. Just
Okay, I can share again, but
you can go to Zoom, then share and the whole screen. I'm not sure if you're sharing.
now is the same.
No, you are clicking on the PowerPoint, which is not good. You need to. Okay, I stopped sharing again. So when you click share, then a window opens and you click on the screen option, which is in the upper left corner, not the presentation. You are clicking on the presentation editor, and we are just seeing the editor then.
Okay. I will share again. So. So is the same or not?
We are still seeing the PowerPoint editor, and I assume the slides won't move for us. Unless you move the slides in editor, this editor which we can see now. I'm not sure. What do you see? Can you tell us what do you see? Do you see it full screen or?
I can't see my presentation at the screen of the conference. So can I send to your email and can sharing you?
Oh, I don't have the option because then you won't have, we won't be able to move the slides. I advise you that you leave it as it is right now, and just move on the left side. You move the slides, if you can see. So you in PowerPoint, you will just move the slides on this left side here, where you see the numbers on the slides. Is that okay?
Okay, I will try again.
Because we can see this PowerPoint editor, but you will have to move the slides there.
So I click the sharing the material at the screens. I will type share.
Yeah, if you have
It's
the option to share
visible
the
to
whole
you
screen,
now?
it is visible, but in the editor. So if you just move the slides on the left side, like you see do you see the numbers and the slides on the left side?
Yes.
Yes, and just you will just click on the slides on the left side, and they will move for us. So, for example, this is the first slide.
Okay.
Yeah.
Okay.
For example, click on the second slide.
Okay.
If you
Can
just click on the second slide, you see if it's moved for us. Just just see.
Okay. Okay.
You click? Yes, like
So,
that. Okay.
okay, I will
Okay.
do in this manner. Can I continue? Okay. It's visible? Is visible for
Yes,
you?
this is
I can
visible, and if you will
continue?
do it like that, then you can continue. Yes.
Okay, thank you. Sorry for these problems, but I'm not very good in technology use. Hello, everyone. My name is Valentina Angela, and together with the Professor Erda Shori, we have prepared the material with the topics preventive care in the health systems, impact of the improvement of population health. Preventive care is a fundamental component of health systems, aiming to reduce morbidity and enhance population well-being and lessens the overall on healthcare services through interventions such as vaccination of the populations, health education, screening programs, and routine medical checkups of the populations. Progressing and check up the chronic disease can be limited, quality of life improved, system efficiency strengthened. In many health systems worldwide, preventive strategies are increasingly recognized as essential for promoting long-term public health and reducing healthcare costs. The objective of this study is to analyze the impact of preventive care within the health system's contribution to improving population health outcomes at border country-specific level. To realize these studies, we have combined the methodology integrating systematic literature review with empirical literature review collection, exactly from including publication from PubMed, Scopus, Web of Science, and Google Scholar, focusing on prevention, care, and public health interventions. And also we have realized one study that is continuing and in this moment, but to present in the conference the numbers of the persons that are fill the questionnaire are 45 persons. We have used standard question, exactly who steps question. The information collected, the data were analyzed and interpreted in the context of international literature also. So I can continue with health risk behaviors and health protective behaviors. Health risk behaviors are harmful actions that increase the likelihood of developing. I can mention at least 5 categories of behaviors have been consistently linked to increasing morbidity and mortality. So consumption of a diet high in calories, fats, and sodium, and low in nutrients, low levels of physical activity, and high levels of sedentary behavior, tobacco use, substance use, including alcohol, engagement in risky sexual behaviors. These are the aspects that are found at the international literature and also in the other and in our studies. On the other hand, health protective behaviors are actions that reduce risk to disease, facilitate recovery. To associate with good health status and disease recovery, it's important being physically active, consuming fruits and vegetables, and following the doctor's instructions for the medicines, especially at the people that have chronic disease. I will continue from the information that the other studies from international literature have found, and exactly from the data according to the data from the Center of Disease Control and Preventions, currently 21% of American adults, 20% of college students, and 6% of high school students use tobacco. In England, the percentage of adults who report tobacco, including cigarettes, is 21%. The prevalence of risky alcohol consuming appears to be somewhat higher in England than in the US. About 1.7 of American adults consume more than 1 or 2 alcoholic drinks per each day, every day, and the others 4 to 5 consuming at least 4 to 5 drinks on an occasion. So in England, 33% of men and 60% of women report risky alcohol consuming. I will continue with another problem about 1.9 million deaths per year attributed no physical inactivity, and this is a global problem, such as we can treat in this material. And I will continue with the results that we had gathered from our study based on the data collected from 45 participants in Albania. So we can see, and in this PowerPoint, the largest number was between the largest age group are 18 to 25 years, exactly 64.4%, and the other age group we can see the separate education level. Most participants have higher education, about 63%, and the other part has a master's degree. Most of them lives in urban areas, and about the financial status, about 68% reported good financial. So I will continue with the habits of the daily routine. Tobacco use. Regarding daily tobacco use, about 89% reported that not smoke, but when we asked if others smoke near them, about the half of the participants reported they do smoke in their presence. Alcohol consuming, about 46% reported having consumed alcoholic at least once. Fluids consuming, about 56 reported consuming fluids only 1 or 2 days per week, and the other part consuming 5, 4 or 6 days per week. About the salt of the use at the daily food, about 29% reporting using a high amount of salt in their daily food. Physical activity, and this is a global problem, such as I mentioned below. Most of the participants, about 82%, reported not engaging in any physical during in their free time. Medical consulting, about 47 had consulted a doctor or other healthcare professional in the past 12 months for routine control of any problems, and the other have not this consulting. So from the International of Global Literature and the healthcare specialist healthcare service suggest the preventive care activities for the populations. I can mention keeping clean and public health, which provides service for the protection of the health, prevention and control the infections disease. That is very important, and many specialists realized from the education and the recommendation of population, food safety and keeping clean supervision, and this is more important at school cafeterias, restaurants, sales points, workplace safety and preventions. And the other recommendation or instructions, individuals' preventive care, which focus on specific screening programs for prevention of serious disease, such as disease of the cancer. So the control at minimum 1 year should everyone prevent. So I can go to the conclusion of the study. Preventive care has a measurable impact of population health, reducing morbidity and mortality. Integration of vaccination, health education, screening program, and lifestyle can improve overall population well-being, reduce healthcare costs, and increase system efficiencies. And risky health behaviors, tobacco, alcohol, physical activity, and healthy diet, risky sexual behavior remain widespread globally and hinder the effectiveness of preventive programs. So at the end of the study, I will continue with the recommendations, strengthening preventive policies, develop the implement national strategies that ensure equal access to prevent services for all citizens, expansions to evidence-based programs, implement more programs for vaccinations, health education, screening for chronic disease, and promotion of physical activities. And the second is a global problem, monitoring and performing evaluation, establish mechanism for monitoring, measuring, and reporting the effectiveness of preventive care. Reducing, reduction, conduct public campaigns to reduce tobacco, alcohol, and other substance abuse, improve diet, and promote physical activity. The fifth, addressing health inequalities, focus on vulnerable populations and areas with limited access to reduce regional and socio-economic disparities. And the second, among the healthcare, foster cooperation among the healthcare, education, labor, environmental sector to improve the effectiveness of prevent program for the all populations. We can use some reference from literature review to realize the study. Thank you for your attention.
Thank you very much for your presentation. Our next author is Aravindan Anandan, professor from Vidyashilp University.
Hi, am I audible?
Yes, you are welcome. He will represent us the paper with title Regulatory Fragmentation versus Foundational Rights, Securing the Right to Health in the Era of Global IE Standards. You can start your presentation, Professor.
Give me a moment to share my screen. My presentation is there.
With your presentation, thank you.
Yeah, thank you so much. Thank you so much.
Can you go closer to your microphone because we hear you?
Okay, am I audible?
I guess you can start your presentation. Go ahead, please.
So good morning to all of you and good evening to my part of the country. So I'm from India. My name is Arvindan and I'm a faculty at School of Law at Vidya Shilp University, Bangalore in India. And this is part of my PhD work that I'm looking at the regulatory fragmentation and the foundational rights per se. So my PhD thesis is broadly on the ethical and legal concerns of AI in healthcare, and this is a part of it. It's a very brief presentation, so I'll not take more than 5 minutes for this. So to start with, just a second. Yeah. So we know that there is a common dilemma in our era regarding the use of AI. AI is a masterpiece of statistical efficiency. It optimizes for fast route and the cheap tools and highest probability, but at the same time, when it comes to the questions of human rights, specifically right to health, human rights per se does not really care about efficiency, but more in optimization of equity, dignity, and fairness. And machines, unfortunately, don't have the empathy. They just do the math. And when we allow algorithmic determinism to dictate who gets the hospital bed and who doesn't, we aren't just facing a technological glitch. Thereby, we are facing a fundamental human right violation. And the question is, how do we prevent machine logic from overriding human fairness? So, coming to the question of integrated governance, the fragmented world, which is the other part of my topic. We talk a lot about the global standards, but the reality is massive regulatory fragmentation that we have. Because, for example, in EU, we have a risk-based AI Act, and when it comes to US, it relies on the market-driven FDA guidelines. But in the global south, it is left with navigating patchwork for local rules. So the AI code travels at the speed of light. And, when it comes to making of law, the speed of bureaucratic committee, unfortunately, comes there. This fragmentation that I emphasize on my research creates what I call as the legal black holes. It allows what we call data colonization, where the global tech giants extract massive health data sheets from vulnerable population in the global south to train their models without offering any sovereign legal protections or equitable returns to those very people. Now, when you apply AI in preventive care, there is obviously a bias trap, which is obvious there. When we look at the preventive care, AI's predictive power is practically magic, but there is a massive trap. If a predictive AI model is trained exclusively on demographic data from, say, Boston and Berlin, as I mentioned, unfortunately, it is going to statistically misdiagnose or completely ignore the health risk of a farmer in India. In the eyes of law, deploying an untested bias algorithm isn't a software bug. It is an algorithmic exclusion. It is a systematic denial of right to non-discrimination. Now, coming to the black box issue that I'm highlighting. When we step into a clinic, precision is everything, but AI introduces the black box problem. I refer the legal framework as a black hole, whereas when it comes to AI, as we all know, there is a black box problem. If a doctor relies on an AI tool and the AI hallucinate, the fatal misdiagnosis. And in such cases, the question of who do we sue, typically a tort law, traditional tort law completely breaks down here. We can't put obviously a server in the prison. If we arbitrarily punish a doctor, we freeze clinical innovation. If we let the foreign software developer off the hook, we abandon the patients. This liability vacuum is direct, dangerous result of regulatory fragmentation. Now, coming to the protecting human agency, the nursing workforce, as we look to the future of our medical workforce, we have to legally protect human agency. AI should be legally classified and restricted as an administrative tool, not a clinical replacement. We need to mandate a human-in-the-loop protocol in our legal frameworks. Let the AI do the heavy data lifting and the paperwork, so our nurses and doctors can actually look into the patients in the eye once again. We protect workforce well-being by ensuring the machine servers the human, not the other way around. Now, why do I come, the background that I come from, I would say that India becomes a good testing ground, and that's why I thought it's relevant to highlight the studies' relevance in India. Now, I say that if you want to test whether a global standard actually works, you have to bring that to India. That's the statement that I'm making. With the 1.4 billion citizens and 22 different languages that these people speak, and unparalleled genetic and socioeconomic diversity, India is an ultimate stress test. You cannot completely copy-paste a Eurocentric AI framework to a continent like India, a subcontinent like India, and expect it to hold up. Therefore, I would say that in your AI health law hasn't been tested in India. It is in global standard. It's only it's just a regional plot project. Now, highlighting a little bit of laws in India, I highlight the Article 21 of Indian Constitution, where I highlight the digital divide. The 70% of our advanced healthcare infrastructure only serves the 30% of urban population. AI requires pristine, digitalized economic health records, but what happens to rural populations whose data is unstructured and non-existent to an AI? They simply do not exist. As a constitutional lawyer, I look at Article 21 of our Constitution, the right to live a life which implicitly guarantees a right to health as well. If only AI recognizes digitalized versions, it mechanizes inequality and directly violates the Constitution. To fix this, we have, in India, we have a legislation which was framed in 2023. We call it as the Digital Personal Data Protection Act. It's a robust shield that strictly defines the data fiduciary, that is the hospitals and the tech companies, and the data principal, the patient. But this is the irony of the law, that the DPDP Act in India relies heavily on informed consent. And the question remains as to how exactly do you obtain meaningful informed consent to train a complex neutral network from a patient who actually lacks basic digital literacy. The law actually looks great on paper, but in practical sense, it's highly fragile. Now, there are certain ethical guidelines. We have an Indian Council of Medical Research, ICMR, which recently laid down some excellent ethical guidelines for AI in biomedical research, demanding data minimalization and continuous human oversight. But let me be blunt on this statement that guidelines are polite suggestions to billionaires. They are soft law. Until these ethical principles are codified into enforceable statutory law, the corporate compliance remains entirely voluntary, and the patient remains legally exposed. To be more precise, I come from my home state is Kerala, which is the southernmost part of India, and in India, Kerala has the highest literacy in India, and in world-class standards, we have 98% of population who are literate, and we have a decentralized public healthcare system. We had a Nipah virus outbreak just prior to the COVID-19 outbreak. The state utilized aggressive AI-assisted data mapping to contain the spread. It saved a lot of life. But because they utilized foreign SaaS platforms to process the data, it triggered a massive legal war over the fundamental right to privacy because people's movements were tracked by the government. It proved that in crisis without sovereign unified data laws, the tension between public health and constitutional privacy will absolutely explode. Now, access to justice has always been a bottleneck when these systems inevitably fail. When an AI wrongly denies a rural patient's health insurance claim, they harm. The harm happens in milliseconds. The traditional courts in India, unfortunately, however, take a decade. I'm sure that's the case with many of the modern legal system also. When it comes to rural population, a patient cannot afford to fight a long 5-year or more than that legal battle against the multinational AI developer. Our justice system is currently a massive bottleneck in the digital age. The speed of algorithmic harm is entirely outpaced the speed of justice. Now, a small model that I want to put forth here is something we call it as the Log Adalat in India. So that's the solution through my research that I'm trying to propose. In India, we have a history of indigenous legal innovation. We use Log Adalat, which translates to People's Court, to resolve disputes rapidly, informally, and equitably at the grassroots level. My proposal is that we must urgently modernize this alternate dispute resolution model for the digital age as well. We need decentralized tech tribunals specifically designed to handle law-level algorithmic health disputes, ensuring the law moves fast as a technology. Now, as part of my research and as part of the institution that I'm belonging to, we are currently spearheading interdisciplinary project that map these exact legal tech portals. We are actively working on the frameworks to translate theoretical rights like the right to exploitation to actionable, localized legal code for the global south. We cannot solve global fragmentation problem in isolation. So I'm using this platform to officially invite global collaboration as well. To my fellow panelists and to the institution turning in, we welcome partnership to build us these localized, equitable AI legal platforms. And to conclude, the integration of artificial intelligence to our clinic and our governance is entirely inevitable, but the equitable access to technology is not. Technology advances on its own, justice must actively chosen. We must ensure that our global legal standards are rewritten not merely to protect technological innovation, but to unconditionally shield the foundational rights of the most vulnerable patients among us. So that is my conclusion, and these are my contact details. I invite collaboration from the panelists or anybody who's interested to be part of it. Thank you so much for listening to me.
Thank you.
Thank you.
I would like to call out the next authors: Valentina Pavlović Vinogradac, expert change solution; Marian Vinogradac, PhD candidate, Psychologum, University of Zagreb, Faculty of Education and Rehabilitation Sciences; Daniel Bursac, lecturer, University Hospital Mercur, University North, to present the paper with title "By Joint Salary, Work-Life Balance and Interpersonal Relations as Key Drivers for Future Nurses." You can start your presentation. Are the authors here?
I don't think
Valentina,
they are here. I cannot see them online.
Valentina Pavlović Vinogradac, Marian Vinogradac.
No, nobody's online.
Okay, that should be our last presentation in that panel. I would like to open now the discussion and question session. If you have any questions, if you have any suggestions for discussion, please go on. If you don't have any questions, then I suggest we should close that session, and you can take a short break before the next session begin at 50:30. Moderator will be Luca Schlosser, researcher at Alma Mater Europaea University, and you will go on with the next panel. Thank you very much. I hope I will see you next year again at the next conference. Thank you very much.
Thank you.
Good afternoon, everyone. I think we can start. So welcome to session 27 on health sciences, which will focus on several European projects addressing different aspects of health, sport, and community development. So my name is Luca Schlosser, and it is my pleasure to moderate this session today. So please remember that each presenter will have approximately 10 minutes for their presentation, followed by a short discussion. I kindly ask the speakers to respect the time so that we can keep the session running smoothly. I'm very glad that we have a lot of participants, currently 53, so I hope you will enjoy the session today. Let us begin with our first presentation. The first presentation is titled Move for Brain, Beyond Sport Through a No Brain, No Game project, and the presenter is Martina Umeton. So Martina, the floor is yours.
Thank you very much, Luca, and thank you all for inviting me here. I will now share my screen so you can see my slides. Let me know when you see it, so I know that everything is good. Okay.
Yeah, you can start. Thanks.
Good. So I'm here today representing a partnership of Play More, which is an Italian organization I represent. Our main objective is to provide sports well-being and participation for all. Then Alma Mater University and ITOI Thessaloniki. We're working together on the Move for Brain project, which is a project financed through the Erasmus Plus sports program. But before I can tell you about the real innovation of the Move for Brain project, we need to take a step back and actually mention the Brain project, which is its predecessor. The Brain project was also financed by the Erasmus Plus program, and its aim was to integrate multisensory experiences into early childhood sports education as a whole. In its 2 years, it served 300 children, and it provided 20 training workshops for personnel involved in sports education. The idea to create a follow-up on this actually came from a pilot phase that was presented during the Brain project for children with mild disabilities. These pilot phase actually highlighted a gap in the initial methodology. And this gap was that the inclusion and development of children with mild disabilities actually requires a very tailored approach that goes beyond the traditional sports education and beyond what the BRAIN project had developed. So the main aim of Word for Brain is actually adapting and expanding these enriched environment methodology to create a very tailored evidence-based activities that stimulate motor and cognitive development in children with mild disabilities in particular. So when we talk about enriched environments, we're talking generally about a setting that offers a higher variety of multisensory stimulation, so visual, auditory, tactile inputs, which is actually aimed at enhancing cognitive functions and learning. And it has been shown that this has a very powerful therapeutic aim in children's development, especially during the ages from 6 to 14, where the brain is more adapted to develop. So in children that were exposed to these enriched environments, we see a higher stimulation of cognitive functions and of the nervous system, the facilitated acquisition of motor skills, even those that were initially found to be more challenging, and enhanced learning memory mechanisms and partial mitigation of neuronal impairment in children with cognitive delays or developmental disorders. So the aim of the project is to actually provide these enriched environments in physical activity. So what we posit is that when we expose children with and without disabilities, with disabilities in particular, to a structured physical activity in those enriched environments, we can actually improve their motor skill proficiency, which then in turn improves their cognitive development, which then in turn improves their executive functions. And what we should see, and what we think we will see, is more successful academic and social outcomes. So we are moving away from the facilitated exercises for children with disabilities, which is the standard usually in education, so usually facilitate activities, but these can inadvertently hinder development. What we want to do is to provide cognitively challenging activities. And these can also help with the inclusion. So by shifting the challenge from physical prowess to actually a cognitive challenge, we can actually propose the same activities to children with and without disabilities. And these can create empathy, it creates bonding, and it creates social inclusion in particular. So I wanted to give you an example of what these enriched environments are. We were actually in Slovenia, in Portorož, on Friday, and we had the amazing opportunity to assist a physical education class in an elementary school aimed at serving children with cognitive and sensory disabilities. And what we saw was that children were challenged while doing physical activity to react to different sensory inputs. So for example, they were running on different surfaces, uneven surfaces. They were supposed to react differently to different textures, different colors. They were hearing instructions while they were moving. And the very powerful thing was that the instructor never showed the children how to get over the obstacle. And you could see in real time their brains kind of developing and being stimulated to find, okay, so how do I, with my physicality, with my possibilities that I have right now, how do I get over this obstacle? And at first, it was really slow. The children needed to see and experiment for themselves what worked for them. And then you could see it immediately, that when they were put in front of a similar obstacle, then the reaction was much quicker. And these putting children in front of an obstacle and letting them figure it out, it's very transferable to all facets of life. And it is very important for cognitive development, and it can be actually transferred to any other challenge in life. So it's It was really fascinating to see. And before stopping, I wanted to just briefly go over with you the Our Move for Brains framework. As we said, we are moving through a learning through movement process. So what we did was we developed some guidelines for these for creating these enriched environments and doing physical activity in these enriched environments. We were able to see this in the instruction workshops in Slovenia, and now we are going to bring this back to our home countries, to our home context, because what we saw is that there is a difference, of course, across countries. We're talking Italy, Greece, and Slovenia. And we are going to experiment what we saw and what we studied in our own context with our own children. We're going to see what needs to be adapted. And then we will train our trainers to actually be able to do this with children during our summer sports camps. At the same time, we don't want this to be something that we only do for ourselves. We want this to be an actual shift in how physical education is viewed and used as not only recreation, but as a tool for cognitive development. So we are doing some advocacy with stakeholders, institutions, and we are developing also an online tool to be able to serve economically disadvantaged areas that are remote and harder to reach, and that lack favorable conditions for the inclusion of these disabled children. So we're moving these two directions, and we look forward to this to show you the results and have you collaborate with us. From my side, I'm done. I thank you very much for your attention, and I give the floor back to Luca. Thank you very much.
Thank you very much, Martina, for the very nice presentation. I will now open the floor to questions. Do we have any question from the audience? Otherwise, I have a question for you, Martina. So we've seen some pictures from the workshop, but I'm interested, can you explain whether any specific equipment is required to implement those motor cognitive activities effectively?
Sure. There is no specialized equipment needed. Everything that was used was just regular gym equipment. So this is actually very transferable to any setting. What was used was we used common objects and assigned a meaning to them. So for example, we had mats, which then provided instability. So you can run on the even surface and then you run on the mats. We used plastic circles, but if you put one, you need to use 1 foot. When you put two, you need to use 2 feet. So any regular object can actually be used in these adapted environments. The important thing is to make sure that the children are stimulated from various points. So receive auditory stimulation, touch stimulation while they're doing the physical activity, and that improves the cognitive development.
Thank you very much.
Thank you.
Do we have any other question? Okay, thank you, Martina. Let's move to the next presentation. Actually, I'll be the one who will present the next project. So I will present the project called NeuroSteps, Bridging Skills in Sports Coaching for Inclusive Development. So let me just share the presentation. Okay. I think you can see it, right?
Yes.
Yes, we can see
Thank
it.
you very much. Okay. So the project which I will present you today is an Erasmus Plus mobility project, K182, that was funded in 2025. It started actually in September 2025, and it will run until September 2026. So the coordinating organization is the Association Movement for the Brain from Slovenia, and the hosting organization is Aitoi Thessaloniki, an association from Greece. So the two organizations already collaborated in the past in an EU-funded partnership project, which somehow laid the foundation for this mobility. So let me just briefly say a few words about the two associations involved in this project. So on one side, the Association Movement for the Brain focuses on developing and delivering evidence-based motor cognitive activities. So the ones that Martina just presented, so very similar. So the founders of the associations are researchers. So our programs are, let's say, strongly grounded in scientific evidence. So also these programs are implemented in an enriched environment, which is, as Martina already introduced, a multisensory setting designed to support and enhance learning. On the other side, Aitoi Thessaloniki from Greece is an association that provides activities for people with special needs. So their work focuses on promoting inclusion and equal opportunities, and they engage people with special needs in a wide range of educational, social, and recreational activities. So when approaching an Erasmus Plus project, it is very important to consider the key EU priorities. So it can be, as you can see in the slide, inclusion and diversity, green Erasmus, the digital dimension, and common values, civic engagement, and participation. So in our case, we choose to focus particularly on inclusion. Our aim was actually to create positive changes in our local environments by combining the expertise from the Greece partner and our own expertise from the Association Movement for the Brain from Slovenia. On this slide, I included actually a few scientific publications that demonstrate the positive effects of motor cognitive activities and enriched environments for this population. So motor cognitive activities combine physical movement with cognitive tasks, as was already introduced. And the cognitive tasks could be like attention, memory, problem solving, inhibition. So this dual engagement, the motor and the cognitive task, stimulates different brain processes at the same time, and this can actually support both cognitive and motor development. So enriched environments, on the other hand, provide a stimulating setting with different sensory, also social and motor opportunities. So such environments encourage exploration, active participation, and learning through this interaction with the environment. So together, these two approaches, the motor cognitive activity and this enriched environment, create a very supportive context that can enhance development and participation also. So these principles are already applied by our association in Slovenia, as you can see from the picture. So on this slide, you can see some of the examples of our activities. So in the first photo, the children during our sport camp are standing on an unstable surface. In this case, it's the SUP board. And they're actually performing different cognitive tasks. Okay, so like, I don't know, switching positions or responding to different instructions. So this allows us to train motor and the cognitive skills at the same time. In another activity, so you can see the second picture, children need to collaborate to complete the task, so which also promotes social interaction. We also use technology, as you can see from the third and the fourth picture, to create this enriched multisensorial environment. So for example, you can see the fit light system. So participants need to react to different light colors or inhibit the irrelevant ones, which trains at the same time attention and also inhibitory control. We also use virtual reality to improve these visual spatial abilities, recreating environments where participants need to process the visual and the auditory stimuli at the same time. So our goal was actually to, and it's currently to adapt these types of activities also for people with special needs. This is something that we want to learn this expertise from the Greek partner. And for this reason, we applied for this project, and some of our trainers will spend a period in Greece to improve their expertise and learn new approaches for working with this population. So the first two trainers are currently in Greece, and on this slide you can see some of examples of the activities they are currently involved. So such as, I don't know, yoga sessions, activities in the fitness center, athletics, a boccia. So this is a very like a special, an adapted activity for people with special needs. And these experiences help them better understand how to design inclusive activities and adapt those activities to the needs of participants. And so what we actually want to achieve, so in the first instance, to strengthen the capacity for inclusive coaching. So trying to implement those activities as part of our weekly program in our territory. So designed especially for or adapted for children with mild disabilities. And of course, organized inclusive summer camps. And this is the last slide. So if any of you is interested in learning more about the project or perhaps collaborate with our association and following our updates, you can just scan the QR code to visit our website. Thank you for your attention, and I will now open the floor to questions. Is there any question for me? No questions. Everything was clear. Okay, then. Thank you very much. Let's then switch to the third presentation. So the project is called Smart Start, Enhancing Early Childhood Development through Integrated Motor Cognitive Sport Activities. And the presenter is Veronica Predovnik. So Veronica, the floor is yours.
Thank you. Can you all see it? Okay.
Yeah.
So
You
yes,
need to
hi.
make it full screen. Just make it full screen.
Please.
It should be full screen.
Then
No.
you should click new share and share the full screen. It's in
Okay,
the upper
wait.
left corner. I think it says screen.
Mm.
Should have that option in the upper left corner, I think. When you click share button.
Hmm.
Oh, you still don't see the full screen. You see the full screen?
I see it in full screen, so I don't know what's wrong.
We don't.
You did not click on the screen option. You clicked on the PowerPoint option, I assume. So if you can do the share screen again, but instead of option, you click. When you click on the share button, it opens a new window, right?
Mm-hmm.
Click on the screen. It's in the upper left corner, not the PowerPoint presentation. Yes, now it's
Yes. Okay, great. Sorry for the delay. So yeah, my name is Veronica, and today I am presenting an overview of a European funded project named Smart Start, Enhancing Early Childhood Development through Integrated Motor Cognitive Sports Activities. Optimal early childhood development is highly dependent not only on genetic factors, but also on the quality and diversity of experiences, including sports programs that stimulate both motor proficiency and cognitive development. Research confirms that motor cognitive stimulation in early life is key for neuroplasticity, executive functions, and pre-literacy skills. However, in Italy and coastal Slovenia, structured physical activities in the preschool environment are severely limited, often beginning only at the age of 10. According to Slofi data, children in the Slovenian coastal region, like Piran, are consistently scoring below the national average in physical fitness tests. Furthermore, last year's sport development strategy of the municipality of Piran revealed that grassroots sports there lack promotion and engagement within the community. Like Slovenia, Italy also faces the persistent issue of delayed implementation of structured physical activity. Primary school teachers were actually not required to hold specific qualifications to teach physical education until 2022. The new regulations now mandate that all sport instructors in schools must have formal sport education credentials, but this requirement only applies starting from the 5th grade. This means that structured physical activity still begins too late, missing the critical early childhood years when motor and cognitive development are most responsive to intervention. Thus, to address this issue, the municipality of Piran, together with partners Association Movement for the Brain No Brain No Gain and BOR Association, came up with the 2-year-long Smart Start project. Its overarching goal is to develop and disseminate an evidence-based motor cognitive program that will enable the most comprehensive and optimal early development for children. Through research, preparation of program guidelines, and multiple workshops, the project will aid institutional capacity building and policy recommendations to integrate evidence-based physical activity into preschool curricula. Additionally, the project's digital platform will include an online blog tool, allowing institutions to share practices and provide feedback even after the project concludes. The project is moving at a fast pace. In just under 6 months, we have already started with the last specific objective. So first, we have done a literature review to assess physical activity levels among EU preschool children. Then we moved to developing common guidelines for effective motor cognitive skill acquisition programs for preschool children. And lastly, we started training kindergarten educators and personnel just last week. A bit more about this training of kindergarten personnel. It will be achieved in 2 ways. The project will fund the salary of a physical education teacher in a pilot preschool to assist the kindergarten educators there. And the partners will also organize international and national workshop events for several kindergartens. This way, the project partners will finalize guidelines of the motor cognitive program based on real-life practice of sharing the guidelines through practical demonstrations, explanations, and discussions with kindergarten educators. Likewise, the personnel of multiple kindergartens will gain knowledge and experience for providing higher quality early childhood education. And while preschool educators will be empowered to deliver more effective and engaging programs, the workshops and the pilot preschool with a PE teacher will also engage children in high-quality activities and enrich their skills, the children's skills. Here are some highlights from the first workshop we held last week. As you can see, the main part consisted of a practical demonstration with children from a nearby kindergarten, and the preschool staff was observing from the sides. Then the demonstration was followed by a lecture that highlighted the importance of physical activity, teaching children how to fall and how to get back up on their own. Overall, successful achievement of Smart Start aims at increasing physical activity among preschoolers, improving children's development of motor proficiency and executive functions, developing an exchange of good practices into physical education programs, increasing the number of skilled early childhood educators, and enhancing the quality and the amount of physical activity, including for children coming from less fortunate backgrounds. By investing in educator training and early physical activity, Smart Start contributes to inclusion, digital innovation, and health promotion, advancing EU priorities for equality, encouraging a healthy lifestyle for all, and digital transformation. thank you for listening. And if you are interested in learning more about this project, feel free to scan the QR code.
Thank you, Veronica, for the very nice presentation again. Okay, do we have any question from the audience? Any comment? If not, actually, I have one for you, Veronica. So, how do you actually plan to motivate preschool teachers who actually might not have a background in physical education to implement these activities?
Yes, so of course, we recognize that many educators could feel overwhelmed with adding something more to their day, especially when it's something that they don't have much experience with. That's why our Smart Start guidelines are designed to be user-friendly, and our workshops focus on building the staff's confidence through practical demonstrations, showing them that motor cognitive stimulation can be fun and simple to lead, even without a sports background. And alongside the practical demonstration, the workshops contain a lecture to emphasize the importance of physical activity for children and tips for children to staying active with supporting academic data and also first-hand experiences. And of course, last but not least, the one-year pilot project where a specialized PE teacher will work directly within a preschool will allow us to identify the real-world challenges that educators face and thus refine our activities to ensure they are manageable. And this way, by showing teachers the positive impact on children's focus and behavior during the pilot project, we can further build their confidence. And we aren't just giving them a manual, we are like giving them a proven, tested framework that they have seen work in practice.
Thank you, Veronica. Any other question?
Yes,
Tina?
I have a question if I may.
Sure.
Yeah. I wanted to know how often would children be involved in this sort of structured activities? Because I know that children in preschool have a lot of like free play, free time. So would this be sprinkled throughout, or would there be like certain hours dedicated to this sort of structured activity?
I think that is best discussed with the kindergarten educator to see what their day already looks like and where they could sprinkle something in, or maybe just try both. Try to sprinkle it in or try to make time and see what works best.
Thank you.
Thank you. Okay, so let's move to our last presentation titled Green Wheels, Safe and Sustainable Mountain Biking for Healthy Communities. And the presenter is Simon Godetz. So Simon, the floor is yours.
Hi, thank you. Screen 2.
Just make it full screen and then we are.
Okay.
Okay.
It's working?
Yeah.
Good. So hello, my name is Simon Godetz and I'm the president of Mountain Bike Club Bosch from Koper, Slovenia, which is a part of the Istrian region that goes between Slovenia and Croatia. Today I'm going to introduce you to the Erasmus Plus project named Green Wheels, Safe and Sustainable Mountain Biking for Healthy Communities, which we lead together with the beneficiaries, so the partners, Vergo Bike Academy from Croatia and Municipality of Piran, which is one of the few municipalities along the Slovenian coast where we operate. So what were the challenges that brought us to the Green Wheels project? The two main challenges we are addressing with the project Green Wheels are low participation in grassroots sports among residents and underutilization of available natural spaces, especially forest, for sports, recreation, and active lifestyle. And our answer to these two challenges is by promoting the sport of mountain biking. Here in the pictures, you can actually see the actual surroundings of our city, Koper. So it is very green, and it would be a shame not to use it for sport and recreation of public. So why mountain biking? Well, because it is mostly a grassroots sport and actually promotes physical activity in natural environments. But it also has strong cardiovascular and fitness benefits, mental health and well-being benefits, as many of the studies show. The conclusion, for example, that one of the scoping reviews had is evidence suggests mountain biking may contribute to adolescent well-being, particularly in self-confidence, social connections, and resilience. Furthermore, mountain bike is accessible and scalable activity because around most of the cities today you can find a trail or network of trails that are freely accessible. And not only that, as a sport, it also supports sustainable tourism and the development of local communities. But let's not forget just about how fun and exciting it is to actually mountain bike. Now, we had 4 specific objectives with the project. First one is to identify and categorize all potential trails in the local area. Then in the next step, to digitally map these identified trails and to upload them using the Trailfork app. The next objective was to organize cleanup campaigns along local natural paths and trails. And the last one is to organize mountain bike safety workshop to promote safe and responsible riding practices in natural environment. So we already conducted the first 2 objectives, and we uploaded 16 different trails and routes to the Trailfork app, which is the largest mountain bike specific trail map application. Each route includes the detailed description in English, Slovenian, and Croatian language. It also serves you with a GPX track to download. You access general info like the distance, altitude profile, categorization of the trail, bike type suggestion, etc. And it's also accompanied with pictures. So this is the first 2 objectives that we already did. But what awaits us in the future is the organization of multiple safety workshops where we will teach others, especially children, the safe approach to this sport, teach them the right techniques in order to advance safely. And we'll do that through beginner courses, advanced courses, and multi-day youth camps. We as a club already do such workshops. So even before the project Green Wheels, we were organizing these workshops and youth camps and so on. But with the project, we'll now have the option to make it even more accessible and approach it to a broader audience. And as I mentioned before, one of the specific objectives are also the cleanup campaigns and maintain your trails, as we call them. So the trail building days, where we will encourage local mountain bikers to join and help cleaning the trails and paths that we mountain bikers use throughout the year and maintain them so that they are safe to use and more fun to use after all. This is actually a big part of our mission, because one of the things that the sport of mountain bike is really unique about is, and I think I couldn't find anything similar in any other sport, is the fact that all or most of the trails that mountain bikers use are actually built by mountain bikers themselves. and this counts for our area and also throughout the world. And I think this also tells a lot about sports ethical values, and that through mountain biking we will also foster like community involvement and teach the young people the responsibility that will do them good later in life also. Thank you. That is it from my side.
Thank you, Simon, for the very interesting presentation. I will now open the floor to questions. Do we have any question from the audience?
I have
Martina?
two actually. Yeah, sorry.
Yeah,
First of all, thank you so much. It sounds like a very interesting project. Maybe want to take up mountain biking. But
Yeah, go for it.
I have
We
a
will
couple
have to.
questions actually. The first one is, are there any provisions for people who may not be able to afford the equipment to be able to still participate in this sport? Or do you plan
Yeah.
on expanding that? Yeah.
You mean through the project Green Wheels or otherwise, like in
Through the
general?
project or otherwise if you plan on expanding to gear to this population?
Well, definitely one of the goals with the Green Wheels project was exactly that with the funds that we will get from European Union, we will actually be able to support especially children that cannot afford to be in this sport, because after all, it is a rather big investment to start with. And that is exactly why I said before with national and international mountain bike safety workshops that we will organize. We already did it before the project Green Wheels, but now with the funds, we will have the options to make it even more accessible, because we will organize also free courses and so on. But as part of the equipment, we are currently, let's say, as a club, already have agreement with different partners, so they can, so the members of our club can buy the equipment cheaper with discounts and so on. So
That's great. Thank
yeah.
you. And the second question regards your environmental side, which I think is a very, very nice touch. When you go on building trails and maintaining trails, do you, how do you say? Sorry, I forget the English word. Do you do any specific activity geared towards soil erosion and sort of respecting the biodiversity of the trail and of the underground? Because I know that hiking, for example, I hike a lot, and in hiking there is not a lot of knowledge about the fact that you're not supposed to step off trail, not only because you get lost, but because you will ruin the biodiversity. So is there any
Yeah.
sort of sensibilization on that?
Well, definitely when building a trail, we always use, and throughout all the world is the same, they always use first natural materials. So we never incorporate material from elsewhere into the trails. So the different objects like bridges, jumps, or whatever, are always made using dirt, rocks, or wood, usually already accessible at the site. Now, the next thing, the one that you mentioned about stepping off the trails that you see in hiking. This is interesting because there are also studies that were made that actually compare mountain biking with the hiking. And what they found is that basically in mountain biking, once the trail is made, people tend to stay on the trail itself and don't go off the trail, just because it's actually first not fun, but also too dangerous because you don't know what's hiding in the grass and so on. So one of the studies actually found out that the trails, the damage that mountain bikers can do in the nature is many times lower than the usual hiking paths.
Thank you.
I'm
That's
not sure
very
if
interesting.
I answered you the
No, yeah, you did actually, and you told me something new, but it makes a lot of sense because, you know, when you're on foot, it's much easier to like wander and step
to
off.
just
While
wander,
if you're like on a bike, you sort of want to follow the trail. Thank you very much for your answers and for your presentation.
Thank you.
Thank you, Martina, and thank you, Simon, for the very interesting discussion. So with this, I will conclude today's session. Thank you very much to all the speakers for their excellent presentations and sharing their activities and insights. So thank you very much, and good afternoon to everyone.
Thank you. Good
Thank you.
afternoon.
Bye-bye.
Thank you.
Bye. So, good afternoon, everyone. We can start session 28 on health sciences, which is actually our student panel. My name is Lukas Schlosser, and I will be moderating this session. So we'll hear several student presentations covering different topics, health sciences, so ranging from human rights in healthcare, neuroscience, physical activity, and also rehabilitation. Each presenter will have approximately 10 minutes for their presentation, so followed by a short discussion. So I kindly ask the speakers to respect the time so that we can keep the session running smoothly. We can start with the first presentation titled, "What is the role of healthcare professionals in upholding human rights?" And the presenter is Harshini Suresh. I'm not sure that I pronounced it correctly.
Yep, that's fine.
Okay, so Harshini, the floor is yours.
Yep, I'm just trying to put my presentation up on this. If that doesn't work, because it's not working right now, I can just do it orally if that's okay.
Just need to press share and then the presentation or screen, it should work.
Just trying to do that right now. Sorry, it's just not.
It worked for everybody else, so you did, like Professor said, you need to click share and then.
Yeah, I don't know if it's my Zoom. I just think it's having a little bit of issue. If that's just trying to go over that again. 2 seconds.
Harshini, if it doesn't work, then just present us the presentation without the PowerPoint.
Yep, sorry. I think that I don't know why it's not working.
Okay, then just start with the
yeah.
presentation.
Yeah. Hello, sorry. So my research paper was on the role of doctors and healthcare workers within human rights. So it basically starts off generally discussing what a doctor's general role is, and often we normally see them as treating wounds and kind of incidents that happen. However, it is important to note that they can be really strong agents in that translate kind of protect the dignity of patients that come in as well. And so usually they're normally seen as state agents and things that are separate from what human rights is. However, in my paper, I argue that they're very important in bridging kind of clinical practice with policy making and patient care as well. And it generally talks about how a human rights-based approach can be framed with general human rights principles. So the principles I do talk about are the panel principles, which engage participation, accountability, non-discrimination, empowerment, and legality, which these principles generally guide clinicians in order to protect and respect the right to health. So often when doctors and clinicians and other healthcare workers are seen as separate to state agents that are usually accountable for protecting human rights, there are cases of dual loyalty. So what happens is there's a tension between state derivatives and patient rights. So examples I included were the Nuremberg Code legacies that as well as force feeding in prisons in Guantanamo, which then shows us that there is a specific need for professional independence and a separate kind of legislation for physicians and healthcare workers in regarding human rights. So there are often systemic inequities, such as the gender health gap, as well as assisted dying, where physicians are also used to preserve life-preserving duties, and balance that with patient autonomy. And so there's many cases within healthcare that physicians are forced to use human rights principles, but often that isn't highlighted. And so in that way, because it isn't highlighted enough, physicians are often stuck in, again, those dual loyalty situations or situations where they're not exactly sure what to do because these situations haven't been discussed, especially like me, especially in states like, especially within medical school as well. So those human rights-based principles aren't often allocated in this area. And so they often have missing education within human rights education or accountability mechanisms. And therefore, when faced with these situations or ethical dilemmas, it's often hard to identify what to do. And although we often talk about medical ethics, there's medical ethics often focuses on the four pillars of healthcare: autonomy, beneficence, non-maleficence, as well as justice. And while they do correlate to human rights-based principles, we often forget how closely it interacts to how people are treated and other human rights. So there's a lot of human rights, but we often mainly focus on the human rights to healthcare, and that's the one thing that healthcare workers are mainly focused on. But because of how intertwined and interdisciplinary they are, health education, accountability mechanisms are all involved in treating patients. And in areas where this dual loyalty situation occurs, or there's been a fall in how the state has been, or a fall or a difficulty in how the state protects human rights of patients, often healthcare workers have to stand up to that. And those are the people, and they're often very under-resourced in these areas, and they have to support the healthcare, their patients through this. And so it's often quite difficult to give them their priority as well as act as advocates, because they're also under state policy and they can't actually act against that in certain states. For example, they can't act against state policy, and therefore they have to they are now facing a situation where they have to fight for the rights of the patient, but also are under the policy themselves. And so they don't have the ability to advocate at that point in time. Sorry, it got quite confusing because I don't have the slides up as well. But overall, I think one of the major things that I'd found out through my paper was identifying that a human rights-based approach should be embodied into different curricula curriculums of medical school, as well as for nursing and for kind of advocating for the rights of patients themselves, and not just focusing on healthcare as just in regards to a patient's health. And also to identify that there needs to be more accountability mechanisms when states themselves aren't kind of respecting that rights-based approach to healthcare, especially now with everything going on in the world. We do realize that more and more that the principles of war aren't actually being followed through. So there's a definite need for empowering healthcare workers to be able to fight for the rights of their patients within these areas, but also creating accountability within states to respect health in general, as well as the rights of both healthcare workers and patients in these areas.
Okay. Thank you, Harshini, for the very interesting presentation. I will now open the floor to questions. Do we have any questions from the audience? Otherwise, I have a question for you. Maybe I missed those informations, but like, can you give us some concrete thing like a healthcare professional can do to protect human rights and in daily practice?
So to protect human rights in daily practice, it's also about identifying inequalities within when giving treatment. So identifying how when patients come in, how their access to healthcare can be impeded, or how they're affected day to day in accessing healthcare, because that's something that we often don't necessarily think about, especially with climate change and everything happening. Right now, there's this difficulty for patients to access specific healthcare needs, or they might not be able to. I mean, I'm from the UK, and so there's the NHS, but in terms of cost as well, in other countries, if they can access healthcare in those areas. So trying to identify the different factors and identifying that different programs within healthcare in terms of public health as well can impact people differently. So that's kind of going into health policy and research, and making sure to address those inequities often helps patients advocate for themselves. And even just giving information to patients generally and giving them the place to advocate for themselves will help them protect their human rights as well.
Okay, thank you. Do we have any other question? Then let's move on the next presentation, titled Frontal Theta Synchrony, Parietal P300 and Entropy Reveal Nonlinear Network Dynamics under Increasing Cognitive Load in a Visual Oddball Task. So the presenter is Filip Iles. So
Hi.
Filip, the floor is yours.
Hi. Can you hear me?
Yes, we can hear you,
Yes,
but we
okay.
cannot see you.
Okay. Wait a minute. I have to. Okay. Do you see me now?
Yeah, we can see you now.
Okay, right. Nice. Wait for me to share my screen. Okay. Can you see it?
No. Okay, make it full screen. Okay, you can
Right
start.
now? It's okay?
Yep. Yeah, it's okay.
Okay, so my name is Filip. I'm a presenter for our research. So we had to work on increasing cognitive load in a visual oddball task. So I'm a psychology major, and we are from Croatian Institute for Brain Research. So why is our research important? Well, it is important because cognitive overload is usually measured with questionnaires. And the questionnaires are very common in psychology, but they're very subjective. They don't capture hidden objective brain dynamics, which was the goal in this research. So we measured through EEG our frontoparietal network, which acts like flexible hub for cognitive control. And it is very important for integrating information and So the frontal-parietal network integrates information across other brain regions, and it allows rapid adaptation and implementation of goal-directed behaviors. So in our study, we asked whether an EEG can uncover hidden changes in brain dynamics during a visual about task. So in our pilot study, we had 5 subjects, and each of them were measured the EEG. So we measured the EEG on each of them. So we used EEG 32 electrode system based on the international 10 to 20 system, which is like a standard. And we measured the cognitive load during a visual about task. So what does that mean? So the participants had to distinct one letter among 6, 9, or 12 distractors, which were also letters. So the experiment was in 3 blocks. So in the first block, the participant had to distinct one letter among 6 distractors. In the second 9. In the second block there were 9 distractors, and in the third block there were 12 distractors. And each participants had 200 trials per block. And after each block, they were given a NASA TELX questionnaire, which measured a cognitive load, and NASA TELX questionnaire, you can see here, this is the first picture. And we measured the 3 markers, frontal theta, parietal P300, and parietal spectral entropy. So this is where it gets interesting. So here you can see the 2 EEG markers across task complexity. On the left side is frontal theta ITC across blocks, and on the right side is the parietal P300 across blocks. So as you can see, the frontal theta ITC drops under a medium low block, 9 distractors, and it recovers under a high load. And so it suggests that attentional networks can reorganize and compensate when demands become extreme. So in contrast, parietal P300 across blocks shows a strong decrease under medium load, and it stays low under a high load. So it reflects like a limitation of parietal evaluation and working memory processes that cannot fully recover. So in the third chart, you can see the correlation between frustration and parietal entropy, and as the participants felt more frustrated, their parietal entropy increased, and we used repeater measures ANOVA, and as you can see, the correlation is 0.625. And to conclude, the NASA TELX questionnaire indicated a linear increase in cognitive effort, but EEG revealed the nonlinear breakdown and parietal recovery of frontal parietal synchrony, and with frustration linked to entropy-based neural complexity. So we propose the parietal spectral entropy as a marker for frustration, because it showed significant correlation. And yes, this is very important because we cannot measure a hidden brain activity only with questionnaires. So we used an EEG for that, and thank you for listening.
Thank you, Philip, for the presentation. Do we have any question from the audience? Otherwise, I have a question. Okay. Can you give me, I don't know if I missed this information can you give me some information about your sample?
So yeah, I used 5 subjects. Well, this is a pilot study. We have to gather more subjects for detailed information to actually research, to actually publish a research paper on that. So the participants were aged between 19 and 21. Yeah.
Okay.
And, yeah.
Do you think would be any differences in enrolling, I don't know, like older adults or younger participants?
Well, I think that the result will be much worse with an older participant. Yes.
Okay.
Especially after age of 25. Yeah.
Okay.
Yeah.
Any other question from the audience? Okay, if not, let's move to the third presentation.
Thank you very much.
Titled Students' Attitudes Toward the Impact of Physical Exercise on Health. And the presenter is Antun Koren. So Antun, the floor is yours. Not sure if Antun is with us. I cannot see him.
I also don't see him.
Okay, so it seems that Antun is not at this session. So then let's move to another one. The presentation is titled The Effectiveness of Virtual Reality-Based Gait Training in Post-Stroke Patients. And the presenter is Zarya Radulovic. So Zarya, the floor is yours. Zarya, are you here with us? We don't have Zarya. And also Antun is not with us. Then I think that's it. Okay. Then this concludes our session. I would like to thank all the speakers for their very, very interesting presentations. And yeah, I wish you all a productive and an enjoyable rest of the Congress. Thank you very much. Goodbye.